Good afternoon. I'm Captain Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA Call, 2023 to 2024 recommendations for influenza prevention and treatment in children, an update for pediatric providers. All participants joining us today are in listen-only mode. Free continuing education is offered for this webinar, and instructions on how to earn continuing education will be provided at the end of the COCA Call. In compliance with continuing education requirements, all planners and presenters must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled product or products under investigational use. CDC, our planners and presenters wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients, with the exception of Dr. Christina Bryant, who would like to disclose that she is an investigator on multi-center vaccine trials with Pfizer and Enanta and receives royalties from Oxford University Press. All of the relevant financial relationships listed for this individual have been mitigated. Content will not include any discussion of the unlabeled use of a product or a product under investigational use, except Dr. Fatima Dawood, who would like to disclose that she will discuss neuraminidase inhibitor medications that are FDA approved only for treating uncomplicated influenza. CDC did not accept financial or in-kind support from ineligible companies for this continuing education activity. At the conclusion of today's session, participants will be able to accomplish the following: highlight key recommendations in the AAP Influenza Policy Statement, Recommendations for Prevention and Control of Influenza in Children 2023 to 2024, and in the CDC Advisory Committee on Immunization Practices document, Prevention and Control of Seasonal Influenza with Vaccines, Recommendations of the Advisory Committee on Immunization Practices, United States 2023 to 2024 influenza season. Review strategies to increase influenza vaccination rates and highlight current health disparities in vaccination coverage. And describe considerations and best practices for co-administering influenza vaccines and other childhood immunizations. After the presentation, there will be a Q&A session. You may submit questions at any time during today's presentations. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note that we receive many more questions than we can answer during our webinars. If you're a patient, please refer your questions to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to welcome our presenters for today's COCA Call. We're pleased to have with us Dr. Fatima Dawood. Dr. Dawood is a medical officer and epidemiologist in the National Center for Immunization and Respiratory Diseases at CDC. Our second presenter is Dr. Christina Bryant. Dr. Bryant is a member of AAP's Committee on Infectious Diseases, and she's a professor of pediatrics at the University of Louisville School of Medicine. She's a hospital epidemiologist at Norton Children's Hospital, and she also serves as the Director for System Pediatric Epidemiology and Infectious Diseases at Norton's Children's Medical Group in Louisville, Kentucky. It is now my pleasure to turn it over to Dr. Dawood. Dr. Dawood, please proceed.
Good afternoon, and thank you very much for speak with you today. For my portion of the presentation, I will cover recommendations for influenza prevention and treatment in children from the CDC perspective. Next slide, please. So I'd like to start by reminding us of why influenza prevention in children remains critically important. Based on data now from many influenza seasons, it is estimated that millions of children in the US get sick with seasonal flu during typical seasons. And based on estimates from statistical models, 7,000 to 26,000 flu-related hospitalizations occurred per season in just children aged less than 5 years during the 9 seasons before the COVID-19 pandemic. In addition, 37 to 199 flu-related deaths have been reported per season in children less than 18 years of age during the most recent 5 pre-COVID pandemic influenza seasons. If there's one thing you take away from today's call to share with children and families that you take care of, I hope it's that flu vaccination remains the best way to prevent flu in children. There are studies that show that getting vaccinated reduces flu illnesses, but also importantly, reduces flu-related doctor's visits, hospitalizations, and even deaths in children. The link at the bottom of this slide, and the slides will be distributed, provides more details about these studies, as well as key facts that you can share with children and their families about seasonal flu vaccination. Next, please. Let's now move to briefly reviewing what we saw with influenza activity during this past season, the 2022-2023 influenza season. Last season, influenza A, H3N2 viruses predominated, but there was also some AH1N1 circulation. And the season was notable for several reasons. First, there was an early start to influenza circulation that began in early to mid-October in most parts of the country. And we saw a single epidemic wave of activity that largely subsided by early January. Second, there were reports of high influenza-associated pediatric hospitalization rates in some areas of the country. And finally, influenza viruses co-circulated with other respiratory viruses, including SARS-CoV-2, respiratory syncytial virus, and rhino and enteroviruses, particularly among children, resulting in increased burden on many local healthcare systems and prompting CDC to put out a health alert notification for people who care for children. Next slide. The next few slides summarize CDC surveillance data that illustrates the patterns that I just described. So this slide shows us data from US clinical laboratories on the left and US public health laboratories on the right. Both of these types of laboratories receive respiratory samples that are tested for influenza viruses. And on the graphs, we can see on the primary y-axis, the number of positive samples tested at the labs, and the x-axis show us epidemiologic weeks. Both of the graphs illustrate the early single wave of detection of influenza that I previously described. And on the right, at the public health labs where subtyping results are available, we can also see the strong predominance of influenza A H3N2 viruses shown by the red bars, with additional detection of influenza A H1N1 viruses as shown by the orange bars. On the left, the clinical laboratory data doesn't include subtyping results, but again shows us a predominance of influenza A viruses with very little influenza B detection. Now moving to the bottom of the slide, this table at the bottom summarizes the percent of samples positive for influenza viruses at the 2 types of labs during 3 time periods: the time period before the COVID pandemic, during the early pandemic, and during this past season. And what we can take away from the table is that the percent positivity in this past season had largely returned to pre-pandemic levels. Next slide. This slide shows data from CDC's Flu-SurvNet surveillance system, which conducts population-based surveillance for laboratory-confirmed influenza-associated hospitalizations and uses these data to calculate hospitalization rates by age each season. So here we see hospitalization rates among children aged 0 to 4 years. And this past season is shown to us with the red line, and the preceding 10 seasons are shown with the other colored lines. The y-axis shows us rates per 100,000 population, and the x-axis is again epidemiologic weeks. So here we can clearly see the early and elevated peak in hospitalization rates among young children during this past season compared to the 10 prior seasons. Next slide. Each year, CDC estimates the burden of influenza in the US using a disease burden pyramid model, where the base is illnesses, and as we move up the pyramid, we go to increasing levels of severity, including hospitalizations and deaths. Mathematical models are used to generate these estimates based on data from CDC influenza surveillance systems and from surveys. On the left-hand side, we see ranges of estimates for the seasons from 2010 through 2020. And on the right, we can see preliminary estimates for this most recent influenza season. And we can see that the estimates at all levels of the disease burden pyramid for this last season fall squarely in the middle of the range of estimates for the 10 seasons before the COVID pandemic, suggesting that this past season was a moderate influenza season. Next slide. This slide shows data on laboratory confirmed influenza-associated deaths in children, which have been reportable events to CDC now for almost 20 years, starting in 2004. The graphs here show reported deaths by season for the most recent 4 seasons and illustrates that the number of reported deaths during this past season was similar to the most recent pre-pandemic season, the 2019-2020 season. Last season, 168 laboratory confirmed influenza deaths in children were reported to CDC. Next slide. So to wrap up this section on influenza surveillance data, this slide shows us data from the World Health Organization's Global Influenza Surveillance and Response System. Because many of the countries in the Southern Hemisphere have their winter influenza season during our Northern Hemisphere summer, or roughly May through August, scientists and epidemiologists often look to the Southern Hemisphere to get a sense of what might occur during our upcoming flu season. So here we can see data from 3 Southern Hemisphere countries, South Africa, Australia, and Chile. And influenza positive samples submitted from these countries are shown for the 2 most recent seasons. If you look to the right of each of the graphs, you can see the most recent season. And we can see that in all of the countries depicted here, influenza A H3 viruses predominated, but in Australia, there was substantial influenza B detection as well. Next slide. Now I want to shift from the surveillance data that we were reviewing to talk about what we know about influenza vaccine effectiveness in children from this past season. In most seasons, CDC estimates influenza vaccine effectiveness using observational data from various study platforms. And this slide summarizes preliminary estimates of vaccine effectiveness against influenza-associated emergency department visits and hospitalizations in children aged 6 months through 17 years of age. The data here are courtesy of the New Vaccine Surveillance Network, a CDC collaboration with 7 US medical centers. What the network found is that influenza vaccine was 49% effective at preventing flu-related hospitalizations in children and 68% effective at preventing flu-related emergency department visits last season. Next slide. So as you have conversations with children and their families about the value of influenza vaccination, consider sharing with them the value of vaccines not only to prevent illness, but also to prevent more severe illness, including medical visits and hospitalizations. Survey data indicate that data such as those I just showed you from the New Vaccine Surveillance Network can be compelling for families who are undecided about whether to get flu vaccines for their children. Next slide. To end this section, this slide includes some additional sources of surveillance data that are a good resource to get more details about the information I shared with you about this past season, and are also a good resource as we head into the upcoming flu season. In particular, I want to highlight the FluView website, which is a good place to look for periodic updates as we move into the upcoming season. Starting in October, there are more detailed reports available. And there is also an interactive feature, it's called FluView Interactive, where you can actually pull down data and look at it by different seasons, age groups, and geographic locations. Next slide. In this next section, I'm going to shift to current CDC recommendations for influenza antiviral treatment. Next slide. As in previous seasons, this season CDC recommends antiviral treatment as early as possible for any patient with confirmed or suspected influenza who falls into one of 3 groups: those who are hospitalized, those who have severe, complicated, or progressive illness, and those at high risk for influenza complications. Antiviral treatment may also be considered for any previously healthy symptomatic person in the outpatient setting who has confirmed or suspected influenza, if treatment can be initiated within 48 hours of illness onset. It's important to note that clinical benefit from influenza antivirals is greatest when antiviral treatment is given early. Next slide. This slide summarizes groups of people who are at high risk for influenza complications for whom antiviral treatment is recommended. In the interest of time, I'm not going to read through all of the groups, but I do want to highlight that children aged less than 2 years are considered a high-risk group, and children and people in general with underlying medical conditions are another high-risk group recommended for antiviral treatment. Next slide. There are 4 FDA-approved antivirals that are recommended for use in the United States. And these fall into 2 classes of medications. The first class are neuraminidase inhibitors, and these include oseltamivir, inhaled zanamivir, and intravenous peramivir. And the second class of medications are the CAP-dependent endonuclease inhibitors, of which there is 1 licensed product in the United States, oral baloxavir. The table on the slide summarizes the differences in the route of administration and the age indications for each antiviral. You can find additional similar information for prophylaxis on CDC's web pages. A couple things I want to note about route of administration and age indications are that oseltamivir and baloxavir are the 2 oral medications available. Zanamivir is administered with a discaler device, and peramivir is an intravenous medication. And with respect to age, peramivir is approved for treatment of acute, uncomplicated influenza in people 6 months of age and older. So it's available for older infants and up. Baloxavir is now approved for treatment of acute, uncomplicated influenza in people 5 years of age and older who are otherwise healthy, or in people 12 years of age and older who are at high risk of developing influenza complications. And lastly, I do want to highlight that for oseltamivir, the FDA-approved age indication includes children aged 14 days and older, but CDC, AAP, and IDSA recommend oseltamivir for treatment of any age down to and including the youngest infants less than 14 days of age. Next slide. So now I will shift to the last section of my presentation, and this section will focus on the recommendations of the Advisory Committee on Immunization Practices for influenza vaccines for this upcoming season, the 23-24 season. And these guidelines were just published online last week. Next slide. So the first thing to know is that routine annual influenza vaccination is recommended for all persons 6 months of age and older who do not have a contraindication to vaccination. Although vaccination is recommended for everyone, there are certain groups for whom vaccination is especially important. And these include people aged 6 months and older who are at increased risk of influenza complications and severe illness. It also includes contacts and caregivers of people who are less than 5 years of age and people 50 years of age and older, and of people with medical conditions that put them at higher risk for severe complications. Next slide. This slide summarizes groups considered at increased risk for influenza complications and severe illness. And I'll walk us through the list here. Children 6 to 59 months of age. I do want to note here that children less than 6 months of age are also at high risk, but they are not able to receive vaccine. Adults 65 years of age and older. And it's this older age group that is considered at increased risk for severe influenza, but note that adults 50 years and older are a priority group if vaccine supplies are limited. Additional high-risk groups prioritized for vaccination include people who are immunocompromised, people who are or will be pregnant during the influenza season, children and adolescents who receive aspirin or salicylate-containing medications because they are at risk for Rye syndrome if they develop influenza virus infection, residents of nursing homes and other long-term care facilities, people who identify as American Indian or Alaska Native, and people with extreme obesity. Next slide. So the ACIP recommendations for the upcoming season, the 2023-2024 season, include 2 updates relevant to the pediatric population. These include an update to the influenza vaccine composition for this upcoming season and an update related to administration of influenza vaccines to people with egg allergy. And we'll talk about each of these in more detail in the next couple slides. Next slide. Influenza viruses, circulating influenza viruses are constantly changing. And for that reason, the World Health Organization and the US Food and Drug Administration reevaluate the composition of flu vaccines annually in February and March of each year. And they do so based on global influenza surveillance data that and make predictions about what may circulate in the upcoming season. There are both egg-based and non-egg-based vaccines now available. And so there are recommended strain compositions for each of the 2 types of vaccines. What's important to know is that the strains selected for each of the 2 types of vaccines are antigenically similar. The main difference is largely in the way that they can be grown for vaccine production. So the update for this upcoming season is a change in the AH1N1 strain in the vaccine. The other 3 strains in the vaccine remain the same as during last season. Next slide. Now we'll talk about the updates related to influenza vaccine administration to people with egg allergy. For the upcoming season, ACIP has made the following updates. Most influenza vaccines are produced with an egg-based manufacturing process, and they do contain a small amount of egg. And in previous seasons, it was recommended that additional safety measures be used for administering egg-based influenza vaccines to people who had a history of severe allergic reactions to egg. The update for this season is that people with egg allergy may now receive any influenza vaccine, egg-based or non-egg-based, that is otherwise appropriate for their age and health status. Additional safety measures are no longer recommended. And it is important to note here, though, that all vaccines should be given in settings where allergic reactions can be recognized and treated quickly. Next slide. This next slide summarizes the information that is not an update to the ACIP recommendations, but it is important for vaccine providers for children to know about. It summarizes available vaccines for children 6 months through 35 months of age and the dosing considerations for this age group. There are 5 inactivated influenza vaccines licensed for children in this age group. And we can see here that there are some differences in the recommended dose of vaccine for the various vaccines. The first 3 vaccines listed all have a recommended dose of 0.5 mLs. In contrast, Influenza quadrivalent has a recommended dose of 0.25 mLs, and Fluzone quadrivalent can be given to this age group at either a 0.25 ml or a 0.5 ml dose. And it's important to be aware of these differences and ensure that an appropriate dose is given. An additional thing to know about for the upcoming season is that Influenza quadrivalent and Fluzone quadrivalent 0.25 ml pre-filled syringes are no longer available. So for Influenza quadrivalent, a 0.25 ml dose has to be obtained from a multi-dose vial. For Fluzone quadrivalent, the options are to either give the higher 0.5 ml dose or for the 0.25 ml dose to be taken from a multi-dose or single dose vial. Next slide. Now let's talk about co-administration of vaccines. Many families, especially during this upcoming season, may ask about whether their children can receive influenza vaccines, COVID-19 vaccines, and now the new RSV monoclonal antibody nirsevimab at the same time. And if this question arises, there are a couple things to know. First, it's important to know that routine administration of all age-appropriate doses of vaccines simultaneously is recommended according to immunization best practices. This is emphasized to avoid missing opportunities for vaccination when children are in the office or another vaccination setting and are able to be vaccinated. Second, COVID-19 vaccines and nirsevimab may be administered regardless of the timing of flu vaccination, and that includes on the same day. If giving the products on the same day, it's recommended that they be administered in different injection sites which is defined as injection sites that are at least 1 inch apart. Next slide. So we will pause here for a knowledge check. Is the statement shown here true or false? A child with a history of severe allergic reaction to eggs should not receive an annual influenza vaccine according to ACIP guidelines. Okay, let's go to the next slide. And the correct answer is B, false. The Advisory Committee on Immunization Practices recommends that all people 6 months and older with egg allergy receive an annual influenza vaccine in the absence of contraindications to vaccination. And in addition, as we learned, for the 2023-2024 ACIP influenza vaccination recommendations, there was an update to state that people with egg allergy may receive any influenza vaccine, egg-based or non-egg-based, that is otherwise appropriate for their age and health status, without the need for additional safety measures beyond those recommended for receipt of any vaccine. Next slide. So I'd like to close here by reminding us of a few things as we head into the upcoming flu season. First and foremost, influenza remains unpredictable. And last season reminded us that influenza viruses can circulate early, they can result in high rates of medically attended illness in children, and they can co-circulate with other respiratory viruses, placing increased strain on healthcare systems. Fortunately, we have an effective tool for influenza prevention, that's influenza vaccination. And so that is why influenza vaccination remains critically important in the upcoming season. Next slide. And on this last slide, we have some additional resources, both for healthcare professionals as well as for children and their families. And again, these slides will be posted on the web and can be accessed there after the call. I will turn things over now to Dr. Christina Bryant.
Thank you, Dr. Dawood. Good afternoon, everyone. Next slide, please. Over the next 20 minutes or so, I'm going to discuss the American Academy of Pediatrics recommendations for influenza immunization and treatment during the upcoming influenza season. Spoiler alert, they align very closely with the CDC recommendations. AAP guidance and my presentation today emphasize strategies to increase influenza immunization rates. And we know we have opportunities with flu. I'm also going to highlight that we have ongoing health disparities with influenza vaccination. Next, please. The AAP policy statement and technical report were released earlier this week on August 29th. The policy statement is a relatively succinct summary of recommendations, and the technical report contains the data that supports the recommendations. Next, please. Now, there are a few things that are new for the 23-24 season. Dr. Dawood has already mentioned that the vaccine composition has been updated. This year's recommendations from the AAP have more information than we've had in the past about immunization of immunocompromised hosts, and I'll share those with you today. We've also added information about improving access to influenza vaccine. We highlight indications for influenza testing, and we call out the availability of at-home testing for flu. Next. Of course, there are many things that haven't changed. Influenza, as you've just heard, continues to cause morbidity and mortality in children. Annual influenza vaccination continues to be recommended for all persons 6 months and older. Any vaccine appropriate for age and health status can be used. Influenza vaccine can be administered at the same time as other vaccines, including COVID-19 vaccine, and it can also be administered to children who are receiving nirsevimab, the new long-acting monoclonal antibody indicated for the prevention of RSV. Antiviral treatment continues to be recommended for certain children with influenza, And as we'll discuss in a bit, recent data suggests that we're not actually treating all of the children with flu who could benefit from treatment. Next slide. In a typical season, about 9% of children develop symptomatic influenza infection. Flu causes significant morbidity, as summarized here. In children who are hospitalized with flu, 20% require treatment in an intensive care unit. 17% develop pneumonia, and this might be a primary viral pneumonia or a secondary bacterial pneumonia, perhaps with Staph aureus or group A strep. 5% of children hospitalized with flu require mechanical ventilation. Up to 10% experience neurologic complications, and this includes both febrile and non-febrile seizures. Every year, children in the US die from influenza. And in children who are hospitalized but survive, post-discharge sequelae occur. This is particularly true in children hospitalized with critical influenza. In one study, 78% of children hospitalized with critical influenza and pre-existing asthma experienced asthma symptoms in the 90 days following discharge, and 13% required readmission. Among patients without pre-existing asthma, 11% had asthma newly diagnosed. Next. Any child can develop complicated influenza, but some groups of children are disproportionately affected by severe adverse outcomes of hospitalization and death. Influenza-associated hospitalization rates are higher in Black, Hispanic, American Indian, Alaskan Native, Asian, and Pacific Islander children. And when Black, Hispanic, Asian, and Pacific Islander children are hospitalized with flu, rates of in-hospital death are threefold higher when compared with white children. We need to better understand and address the social determinants of health that contribute to these disparities. Next. Now, you've already heard that we have safe and effective vaccines that can protect children against the severe outcomes of influenza, but these vaccines are being underutilized. Influenza vaccination coverage decreased again last season. Through April 15th of 2023, only 55.1% of all children 6 months to 17 years of age had received flu vaccine, and disparities continue to exist. Next. Flu vaccination coverage levels remained lower last season in non-Hispanic Black children compared with non-Hispanic white children, Hispanic children, and children who identified as non-Hispanic other. Geographic disparities also exist. Vaccination coverage among children residing in rural areas was just over 41%, substantially lower than in children residing in suburban or urban areas. Next slide. Now, the next two slides contained influenza vaccination administration pearls. When 2 doses of vaccine are required in a given season, it's not necessary to use the same brand or even the same type of vaccine. The maximum number of doses that can be withdrawn from a multi-dose vial is specified in each vaccine's package insert and should not be exceeded. Any residual volume that remains after withdrawing the maximum number of doses must be discarded. As Dr. Dawood has explained, the dose volume recommended for children 6 months to 35 months varies by vaccine. A 0.5 ml unit dose of any inactivated vaccine should never be split into 2 separate 0.25 ml doses. Next slide, please. As you've heard, influenza vaccines can be administered on the same day as other live and inactivated vaccines and can be administered on the same day as nirsevimab. Next slide. Immunocompromised children are at risk for complicated influenza and will benefit from inactivated influenza vaccine. But the timing of vaccine is important to optimize effectiveness. In children with malignant neoplasms, influenza vaccine is ideally administered 2 weeks before chemotherapy. In children receiving anti-B cell therapies in the preceding 6 months, vaccine should be referred until B cell recovery. Children who've undergone stem cell transplant can generally receive flu vaccine beginning 4 to 6 months after transplant, depending on the level of immunosuppression. After solid organ transplant, vaccination can begin 3 months after transplant, but during flu season, vaccine can be considered for some patients beginning 1 month after transplant. Next slide. The number of influenza vaccine doses recommended for children remains unchanged this influenza season and depends on the child's age at first dose administration and influenza vaccination history. Our algorithm has a new look though, so I'll walk you through this. Children 6 months through 8 years of age who are receiving flu vaccine for the first time or who received only 1 dose prior to July 1st, 2023, or whose vaccination status is simply unknown, need 2 doses of flu vaccine at least 4 weeks apart. All other children should receive 1 dose this season. Now, for children who were 8 years of age who require 2 doses of flu vaccine this season, both doses should be administered, even if the child turns 9 between dose 1 and dose 2. Next slide. Give vaccine to children as soon as it becomes available, especially for children who require 2 doses. For some of you in the audience, that means now. You have influenza vaccine on your shelf. Some of you are still waiting for doses, but these should arrive soon. Remember, flu vaccine arrived early last year, and we started the season with more than half of eligible children unprotected. So now is the time to begin to vaccinate. Ideally, children will receive all recommended doses by the end of October, but vaccination should continue throughout the season. Next slide, please. All eligible children 6 months and older should be immunized with flu vaccine, but some special efforts are needed to make sure that children at higher risk for adverse outcomes from influenza receive influenza vaccine. And you've already heard this message, but I think it's important enough to repeat. Children at higher risk for influenza complications include children younger than 5 years of age, particularly those younger than 2, children residing in chronic care facilities, as well as children with certain medical conditions, and those conditions are outlined here. Additionally, this year, the AAP is highlighting that children born early term or late preterm are at higher risk. So now let's talk about how we might improve influenza immunization rates. Let's go to the next slide. We need to get from less than 60% to more than 70% or higher. That's the Healthy People 2030 target. So how do we do that? Individual providers, practices, health systems, and public health partners can take specific actions to improve influenza vaccination coverage. A strong presumptive recommendation from a trusted clinician is associated with vaccine acceptance. Bundling the recommendation for flu vaccine with other routinely recommended vaccines can also be effective. So for example, today your child is due for vaccines to protect him against measles, mumps, rubella, chickenpox, and flu. Practices should educate all team members about flu vaccine, including the front office staff, and messaging about the importance of flu vaccine can begin at check-in. Next slide. Individual practices and health systems can take steps to reduce missed opportunities for immunization. This includes reviewing influenza immunization status at all visits during the season and vaccinating at all visit types. A child with a mild URI or an ear infection can still get a flu vaccine. Now, for some families, getting to the office during regular office hours can be a barrier. And so some practices may have the capacity to offer expanded hours specifically for flu vaccine, or they may be able to host evening or weekend flu vaccine clinics. Some hospitals very successfully offer flu vaccine upon discharge from the emergency department or inpatient units during flu season. Next. We can leverage technology to increase immunization rates. Sending reminder recall messages is an evidence-based strategy to improve childhood influenza immunization rates. Reminders can be delivered by phone, email, text message, or electronic patient portals. Standing vaccine orders and vaccine prompts in the electronic health record are also effective. Systems may utilize the electronic health record to identify patients at risk and provide targeted communication to those patients. The AAP's technical report includes sample value sets that could be used to identify patients at risk and create decision support tools for clinicians. I think it's human nature for all of us to overestimate progress toward a goal when we don't have data. And that's where audit and feedback is so valuable and can drive our efforts to immunize more patients. Next slide, please. Immunization in the medical home is ideal, especially for the youngest child. But immunization of all children 6 months and older between now and the start of the flu season is a big task. If we want to reach all children, we need to partner with community stakeholders, including early childhood learning centers, schools, and pharmacies to increase access. We also need to engage with communities affected by health disparities to promote trust and understand barriers to vaccine access, so we can eliminate these barriers. We also need to make sure that we are getting the message right, especially when we are communicating in languages other than English. Next slide. Precise language matters. The term la gripe is often used in Spanish language educational materials about flu. La gripe is actually an imprecise term, though, that can be used to describe a variety of viral respiratory illnesses, not just influenza. And this can lead to confusion about the actual illness prevented by influenza vaccine and may actually result in decreased vaccine confidence about vaccine effectiveness. Next slide. So the term influenza is preferred over la gripe when communicating with Spanish-speaking patients and families. We're updating our educational materials. Finally, we need to acknowledge, next slide please, that structural barriers exist to achieving our influenza immunization coverage goals. We need to work together to eliminate disparities in influenza vaccine supply between privately insured patients and those eligible through the Vaccines for Children program. Next slide. We also need to work with public and private payers to ensure adequate reimbursement for administering flu vaccine to pediatric patients. Payment systems must be updated so that doses administered in July and August are reimbursed. Out-of-pocket costs can be a barrier for some families, and those must be eliminated. Next slide, please. Now let's switch gears and talk a little bit about testing. Not every child with influenza-like illness needs a flu test. Test when results are needed to inform clinical management or infection prevention measures, or to distinguish influenza from other respiratory illnesses with similar symptoms, including SARS-CoV-2. When flu is circulating, test hospitalized children with symptoms of flu with a molecular assay. PCR tests are highly sensitive and specific and can be used to promptly identify children who need antiviral treatment. For the first time, at-home tests for flu are available for children as young as 2 years of age. In February, the Food and Drug Administration issued emergency use authorization for an over-the-counter at-home test to diagnose influenza A, influenza B, and SARS-CoV-2 infection in symptomatic patients. Now's really the time to think about anticipatory guidance for our patients about if and when these tests might be useful. Practices also need to think about how they're going to manage calls from parents reporting positive at-home tests in children. Next slide, please. Dr. Dawood reviewed indications for antiviral treatment for influenza. I will just include this reminder that antiviral treatment remains underutilized in many healthcare facilities. In a multi-center retrospective cross-sectional study conducted between 2007 and 2020 at 36 U.S. children's hospitals, use of oseltamivir in hospitalized children with flu increased over time, but never exceeded 80%. There was significant variability between hospitals, and the odds of receiving oseltamivir was lower in children younger than 5 years of age. And we know that younger children are at increased risk of complicated flu. Over the next 2 slides, I've listed some useful resources from the AAP. Next slide, please. We have resources for healthcare professionals as well as families. Next slide, please. Again, these resources will be available in the slide set posted online. And let's end with a knowledge check. Next slide, please. Influenza vaccination should only occur in the medical home. True or false? Next slide. This is false. Although vaccination in the medical home is optimal, administering influenza vaccine in diverse locations, including subspecialty practices, urgent care clinics, emergency departments, schools, and pharmacies, may increase uptake among patients who cannot access their medical home or don't have a medical home, as well as those at higher risk for influenza-related complications. When influenza vaccination takes place in a non-traditional setting, appropriate documentation should be provided to patients and to the medical home. And settings that offer flu vaccine should submit details about the vaccination to the appropriate immunization information system or vaccine registry. Thank you.
Presenters, thank you so much for providing this timely information to our audience. We will now go into our Q&A session. And for our audience, please remember to ask a question using Zoom. Click the Q&A button at the bottom of your screen, then type your question. And please note that we often receive many more questions than we can answer during our webinars. For our presenters, we have a few questions from our audience asking about some tips and some best practices for patient counseling. Our first question asks, what are some clear and actionable health education tips you can share when counseling either parents, guardians, or caregivers regarding concerns they may have that the flu shot will give their child influenza?
This is Chris Bryant. I think this is a practical question. It comes up. Parents say, oh, you know, I or my child had a flu vaccine in the past, and then we developed influenza shortly thereafter. Well, you know, what we know is that the flu shot is an inactivated shot. It can't give you the flu. When people develop flu shortly after receiving a flu vaccine, it's because they haven't had a chance to develop antibodies. The shot just hasn't had a chance to work yet. So the shot cannot give you the flu. Live attenuated intranasal vaccine can cause some stuffy nose. And if we're giving that vaccine, we just need to share that information with families. I do think when parents say, I'm reluctant to get vaccine to prevent influenza in my child, it's a best practice to say, tell me more, tell me about your concerns, so that I can answer your questions and address those.
Thank you very much. Our next question is another counseling question, and the question asks, you mentioned about getting the flu vaccine for your children as soon as possible, essentially if it's available right now. And the question asks, what is any recommendation or perhaps any guidance you can share with providers if the parents ask about the immunity waning if the vaccine is administered this early in the late summer fall season?
I can begin to answer that question. So the ACIP guidance related to timing of vaccination takes into consideration several things. First, the unpredictability of influenza virus circulation. Second, opportunities for vaccination and vaccine delivery and practical considerations around that. And third, the emerging data about waning immunity after vaccination. And so taking all of those things into consideration, for most people, the best time to get vaccinated is September and October, with the goal of being vaccinated by the end of October, prior to when we usually see influenza viruses circulating. There are some special considerations for children in particular, though. For children who require only a single dose of vaccine in seasons where vaccine is available in July and August, those children can be considered for vaccination. And the rationale for that is many children come in for well child visits in July and August or other routine care visits. And those are opportunities for vaccination that shouldn't be missed to ensure that children are protected before the upcoming season. The other group of children for whom there's a special mention in the ACIP recommendations are children 6 months through 8 years of age, who will require 2 doses of vaccine to be considered fully vaccinated. And Dr. Bryant talked about who those children are. For those children, again, in seasons when vaccine is available as early as July and August, they are recommended to get their vaccine as early as possible. And the rationale there is to provide sufficient time for them to come in and get their second dose, which has to be given 4 weeks after the first dose, with a goal of having them be fully vaccinated again before the end of October and before we tend to see flu viruses circulating.
Thank you very much for that. Our next question asks, can you share any talking points we can use during counseling when discussing the change in recommendations regarding the egg allergy?
Sure, this is Fatima Dawud. I can answer that, and Dr. Bryant may want to add to what I say. I think there's a couple things to know. First, ACIP updated those recommendations based on an extensive review of the literature, including 20 or so studies looking at seasonal influenza vaccination given to people with egg allergy and outcomes after vaccination, as well as studies from the 2009 pandemic with the monovalent vaccine in egg allergic people. And across those studies, there were no reports of anaphylactic allergic reactions, and other non-anaphylactic allergic reactions were exceedingly rare, less than 1% in the literature. And the ACIP also reviewed data that's submitted to CDC's vaccine adverse events reporting system. So this is very much an evidence-based update. I think another important thing to note is that In general, as Dr. Bryant pointed out, the CDC, ACIP recommendations and AAP's recommendations have for many years been in alignment, but AAP actually reached this recommendation earlier, and since 2016 has had a recommendation that people with egg allergy may receive vaccine without additional precautions beyond those given after any vaccination. Dr. Bryant, do you want to add anything additional?
I thank you for pointing out that the AAP has recommended this for a number of years, that individuals with egg allergy can safely receive influenza vaccine without any additional precautions. I think it's terrific that AAP and ACIP are now very much aligned on this point, and hopefully this will reduce confusion.
Thank you both. Our next question asks, should a child receive the influenza vaccine if they are sick with another respiratory disease?
So this is Chris Bryant. So a mild illness with or without fever is not a contraindication to influenza vaccine. In a child who has more severe illness, you might wish to defer. But if a child comes in with a URI, and they have mild illness, it is okay to give them flu vaccine.
Thank you very much. And we have time for one last question. And the question asks, are there any considerations or factors to take into account when co-administering seasonal or routine vaccines to children while administering the influenza vaccine?
This is Fatima Dawood. I can answer that question. There are not. Influenza vaccines may be co-administered with any of the other recommended vaccines for children. The only consideration is that if multiple vaccines are being given, the recommendation is to try to give them in different injection sites, where a different injection site is defined as at least 1 inch apart.
Thank you very much for that. And with that, I want to thank everyone for joining us today, with a special thanks to our presenters. All continuing education for COCA Calls is issued online through CDC Training and Continuing Education online system at tceols.cdc.gov. Those who participate in today's live COCA Call and wish to receive continuing education, please complete the online evaluation and post-test before Monday, October 2nd, 2023, with the course code WC4520-083123. The access code is COCA 083123. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation and post-test between Tuesday, October 3, 2023, and Friday, October 3, 2025, and use course code WD4520-083123. The access code, again, is COCA 083123. Continuing education certificates can be printed immediately upon completion of your online evaluation. A cumulative transcript of all CDC continuing education obtained through the CDC Training and Continuing Education online system are maintained for each user. Today's COCA Call will be available to view on demand a few hours after the live call at emergency.cdc.gov/COCA. We invite you to join us Tuesday, September 19 at 2 p.m. Eastern for our next COCA Call. The topic will be preparing for the upcoming respiratory disease season, recommendations for influenza, COVID-19, and RSV vaccines for older adults. You can visit emergency.cdc.gov/COCA for more details about this COCA Call and other upcoming COCA Calls. We invite you to subscribe to receive announcements for future COCA calls by visiting emergency.cdc.gov/COCA/subscribe.asp. You'll also receive other COCA products to help keep you informed about emerging and existing public health topics. Again, thank you for joining us for today's COCA call and have a great day.